So it is my great pleasure today to introduce Dr. Stephen Ross, a colleague and a friend, to share with us today his innovative and no hyperbole, groundbreaking work in psilocybin-assisted psychotherapy. Dr. Ross has received his undergraduate degree from University of Pennsylvania, graduated from UCLA School of Medicine, and pursued a residency in psychiatry at Columbia, and then an addiction psychiatry fellowship at NYU. He joined the faculty of NYU in psychiatry and child and adolescent psychiatry, and most recently is the associate director of the NYU Center for Psychedelic Medicine. His research is focused on the development of novel pharmacologic psychosocial interventions for difficult to treat disorders, including addictive disorders, with a focus on the intersection between pain and addiction, psychiatric and existential distress that are associated with an advanced cancer diagnosis, mood disorders, and PTSD. Most germane to today's discussion, Dr. Ross was the PI of one of the 3 seminal pilot studies examining psilocybin-assisted therapies in patients with cancer. This work has truly been groundbreaking and has the potential for really changing the paradigm of how we think about treating psychosocial distress in the setting of cancer. This work has been highlighted, and Dr. Ross has been interviewed in the New Yorker, the New York Times, Michael Pollan's best-selling book, How to Change Your Mind, and he's featured in the Netflix documentary, Fantastic Fungi. If you haven't seen it, I do recommend it. And I'm scratching the surface. This is really only an overview. And in the interest of time, I will turn it over to Dr. Ross, but needless to say, his work is some of the most exciting that I know of in the world of palliative care, and it's like in existential distress. So without further ado, Dr. Ross.
Thank you so much, Stacey. Thank you for such a wonderful introduction. It's a real pleasure and honor to be here today, and I've really enjoyed collaborating with you and Jim, and excited about our future collaboration together. I'm going to go ahead and share my screen. Okay, can everyone see that? Is it sharing now? Yep, okay. Okay, so today I'm going to talk about the use of psychedelic-assisted psychotherapy to treat psychiatric distress like depression and anxiety, and existential distress like the demoralization syndrome and death anxiety in patients that have advanced cancer. And I'll review work that we have done at NYU as well. In terms of disclosures, it's taken NIH a while to start to fund psychedelic research. Again, in the first era of psychedelic research from the 50s to 70s, NIH, in particular NIMH, was heavily involved in funding psychedelic research. And then that really died down for a long period of time. But Stacey, myself, are trying with NCI and making some progress in getting work funded there. I also received research funding from the Usona Institute and Reset Pharma. So in terms of the outline, I'm going to talk about history. The history here is really important and interesting and informs where we are now. We're kind of in this unusual stage of almost irrational exuberance around psychedelics, but we were here before in history, and it's important to be good students of history to understand where things could go wrong again. I'll define the terminology of the unusual states of mind occasioned by this class of drugs. I'll classify them. I'll review briefly some of the neurobiology and what we know of the neuroscience of how they work. I'll review the safety literature, which is very important to pay attention to. And then I'll set the stage for the current studies by looking back in the historical era. And a bunch of us drew heavily on the historical data to come up with the modern trials. And then we'll look at the modern data of the use of mostly psilocybin-assisted psychotherapy in advanced cancer. And then we'll look to the future. So the history of psychedelics have been used by indigenous cultures for millennia. They have been part of religious communities for thousands of years. Psilocybin in particular has been used in Mexico and indigenous cultures there that were part of religious ceremonies. And one of the ways they were used in these religious indigenous communities was to help in the death and dying process. They were tools to help with the process of transitioning to, the afterlife and other worlds, and just the process of dying. The history, the first era of psychedelic research started serendipitously in 1943. Albert Hofmann, who was a chemist at Sandoz Pharmaceuticals, who was working on ergot derivatives, basically looking for vasoconstricting agents to help women who were bleeding during childbirth. And purely by accident, he, using these ergoline derivatives, synthesized a bunch of lysergamides and accidentally got some on his skin one day, went home, had the first LSD experience, and it was not a good one. He thought he was going crazy. He thought he was possessed by a demon. He thought his neighbor was a witch, and called his physician, thought he was dying. Physician found nothing wrong with him, and he had a difficult night, but woke up in the morning feeling refreshed and renewed and having a positive outlook, and knew that he had discovered something unusual. Went back to the lab, figured out what it was. They tested it in animals, humans, and then Sandoz made it available. They synthesized Delicid and made it available for free to psychiatric researchers throughout the world and practitioners. And the idea was that it could be used to understand the biological basis of psychosis, but also it started to be used as a tool to aid psychoanalytically oriented psychotherapy. And so began the first wave of psychedelic research, which was mostly with LSD. And this ended up being a big part of psychiatry. I mean, really, really big. At the end of the era, and towards the end of the era, psilocybin was synthesized in 1958. An anthropologist had gone to Mexico and undergone the first psilocybin session, brought the mushrooms back to Albert Hofmann, and he identified psilocybin as the active ingredient. But most of the historical research focused on LSD, not psilocybin. But by the end of this 20-25 year period, there were over 1,000 studies published. There were over 40,000 participants. The most studied indication was the use of LSD to treat alcoholism. And my primary specialty is addiction psychiatry. So this really piqued my interest that there was so much focus on addiction. But the second most studied indication was the use of LSD-assisted psychotherapy to treat terminal cancer-related psychiatric and existential distress. And there was very promising data there, mostly open label, although there was one controlled trial that I will mention. But before any of this promising body of research could be replicated or taken to the next level, it escaped from the human laboratory. This guy, Timothy Leary, who was a psychologist at Harvard, got kicked out of Harvard and became the Pied Piper of psychedelics. It got taken up by the counterculture movement, and it posed a kind of like threat to the political establishment at the time. And so Richard Nixon declared Timothy Leary the most dangerous man in America, and with Congress in 1970 enacted the Controlled Substance Act, which created the scheduling system we have today and put all of the psychedelics into Schedule 1. This was a political move. This is not a medical rational classification system, but it so effectively initiated the war on drugs, which we've now had for the last 50 or so years, which has been terrible for people with addiction. It's turned a neurologic problem into a sociocultural problem where we put people in jail for having addiction. The other thing that it did is that it erased from the history books completely within psychiatry and medicine that this had been part of medicine. So much so that when I was a medical student, a psychiatry resident, an addiction fellow, I learned zero about any of this history. So it was really interesting to hear about it in 2006 that psychedelic research had restarted with Rick Strassman at the University of New Mexico. Kind of a bizarre place for it to start, using IV DMT in normal volunteers. And these people had very unusual experiences. I guess this was New Mexico, but a lot of them reported alien abduction and some really bizarre phenomena. But then in the late 90s, two research groups, one at Johns Hopkins and one at UCLA, began programs of psychedelic research. And in 2006, our group at NYU started a program of psychedelic research with psilocybin. And again, it was like serendipity. I had gone to UCLA for medical school, but I had never met Charlie Grove when he was there. I was introduced to him, and he encouraged me to get involved in this area of research, gave me his protocol that he was working on for psilocybin and advanced cancer. And we got going. And we've been doing clinical trials with psilocybin since 2006 in advanced cancer and alcohol use disorder and major depression. And we have a whole host of other areas we're moving into. So this created this very unusual model in psychiatry, which we really don't have today. Instead of one therapist, there were two. There were dyad therapy teams. And this was very much conceptualized as psilocybin-assisted psychotherapy. You had the two therapists. They developed this paradigm of treatment where the participant, after extensive preparatory psychotherapy, going into the details of what's going on with their cancer, what's embedding that within their life review, preparing them for the session, including their family members. The sessions took place, 8-hour sessions in a living room-like setting, couch made into a bed. After stating their intention, the default is for the participant to lie supine. They're given eye shades so they can focus internally rather than get distracted by some of the external phenomena that can happen with these drugs. They're given pre-selected music. And this is a different kind of skill set as a therapist. I had been used to 45-minute sessions, but this is an 8-hour session. It is really interesting to be sitting there for that amount of time. And what the patients tell you after these experiences, at first was very hard for me to comprehend. The only lens I had to understand it was that this was psychosis. But it was not. There was something different going on in therapeutic that we did not and still don't have a great nomenclature to describe. So these drugs, the serotonergic psychedelics or hallucinogens, come in two different varieties. There's the indole alkylamines, and these are drugs like the tryptamines that include psilocybin, the lysergamides that include LSD, iboga alkaloids that include ibogaine. This is ayahuasca, which is an Amazonian brew that is a decoction of two plants. One contains DMT, which is the active psychedelic, and the other contains an MAO inhibitor that prevents gut degradation. And then you have the phenylethylamines. These are the amphetaminergic psychedelics, and the prototype here is peyote, which interestingly, is legally used by the Native American church as part of their religion. So we have this strange kind of schizophrenia in our drug laws that if you're using them for religious purposes, the 1993 Religious Restoration Freedom Act allows their use. And this was updated for the use of ayahuasca as well in indigenous groups. So religious freedom, it's okay, but if you're using it recreationally, you can go to jail for a very, very long time. And these drugs taught us a fair amount about neurobiology. They led to the discovery of the serotonin receptor. So this is DMT. This ring structure is very, very similar to serotonin. And this is mescaline. Its ring structure is very similar to norepinephrine, making it an amphetaminergic type psychedelic. The terminology here is all over the place. None of it is great. My favorite is actually Louis Lewin in the 1800s, self-experimenting with mescaline, called them fantastica. Psychotomimetic was the term. People understood that there were some similarities between these states in acute psychosis, and they have taught us some about acute psychotic states and neurobiology. In fact, the atypical antipsychotics, drugs like Zyprexa, all act to block the serotonin 2A receptor. So there's some similarity between their mechanism of action and psychosis. Psychedelic was a term coined by Humphrey Osmond, which meant mind manifesting, which is vague. Hallucinogen is a kind of misnomer. It's that which produces hallucinations. These tend to cause more illusions than frank hallucinations, although they can create frank hallucinations sometimes. Entheogen is a plant-derived compound that occasions the God within. Also, who knows exactly what that means. And mysticomimetic, this was less strange to me than some of my colleagues. I being an addiction psychiatrist, I had learned about the spiritual domain of illness through Alcoholics Anonymous and knew that people that got sober often had these unusual spiritual experiences like Bill W. had in 1935. So I knew some about mystical states, but I also knew that that was not part of medicine. I did a lot of oncology rotations in medical school and residency, and I never learned about the mystical state or understanding the spiritual domain of anybody's illness. This was like religion and not part of medicine. But to understand these states is important because these drugs can induce mystical type experiences, which I'll define now. So mysticism really comes from different branches of religion, but the psychology has studied it since the 1960s. There's a validated scale that measures the mystical experience. And at its core is the sense of unity, that all matter and energy are interconnected, that consciousness is continuous, and that participants can report this sense of oneness within themselves internally and oneness externally with the universe. Participants can report feeling transported to a different dimension of time and space. This was very common. We did qualitative work as well. We would often hear patients say, how can I describe this experience other than I was in touch with love, ultimate love, or God's love? We even had agnostics say, I don't know how to describe this other than I was bathed in God's love. One of them said, I don't believe in God, I still don't, but that's the only way I could describe it. People felt that these states were reverential and sacred and a kind of inspiring reality. They had what William James, the father of American psychology, described as noetics or ultimate reality. They would have a sense that this reality was more real and genuine and true than the regular waking consciousness. The experience was ineffable. They would say, how can you possibly describe infinity? And these episodes were transient. So in terms of the neuroscience, all the drugs in this classification, whether it's LSD, psilocybin, DMT, mescaline, all of them are serotonin 2A agonists. And if you block that receptor, you block their subjective effects. Now, whether that is what's important for their therapeutic effects is yet to be determined, but we know that the serotonin 2A system is key. We also know that these drugs have glutamatergic and neurotrophic effects, that these drugs have been found repeatedly now in animal studies to have neuroplastic effects to repair synapses and neurons. And they work very much like ketamine in this regard. And this is thought to be due and mediated by BDNF and mTOR. These drugs are dopaminergic, but unlike the other drugs of abuse that create addiction, they don't appreciably activate the dopaminergic system and really lack true addictive liability. They also have adrenergic effects as well. Acute neuroimaging has kind of like pointed to this interesting model championed by Robin Carhart Harris, although this is more kind of like neurotheology at this point than what's actually going on. But what we do know, at least from acute neuroimaging, is that you have reduction in brain activity within brain networks and between brain networks. And this is fMRI, EEG, and MEG activity. And in particular, this default mode network seems to get deactivated acutely. And this is thought to be important because the default mode network is a brain system that's heavily involved in waking consciousness, resting brain function, but it has to do with metacognition, mind wandering, thinking about yourself, thinking about the past, thinking about the future. Some think of it as the biological basis of the ego of the self. And in disorders like addiction, depression, it can get overly constrained, that people can get stuck in these cognitive loops that create a lot of emotional distress. And so there was this theory that, okay, if default mode network overactivations involved with these illnesses, maybe dismantling this network temporarily could be helpful. And this is a famous picture now looking at brain networks, that acutely you get a disintegration of local networks, and then you get this reorganization into new networks, and temporarily there's a greater degree of connectivity between the brain, a kind of like increase in plasticity. And that's like increasingly thought to be how they may work, that they take a brain that is like overly constrained and constricted in thinking patterns and behaviors, and kind of like resets things and allows for new patterns and connections and thought processes to take hold that could be leveraged within a psychotherapeutic platform to go after distress. In terms of safety, this class of drugs in general is very safe. They are not associated with organ damage. They're not carcinogenic or teratogenic. In general, they're not associated with overdose deaths. And you contrast this with what's happening with the opiate epidemic. And opiates, interestingly, a class of medications we most certainly want in society for acute pain, for end of life, but have this huge liability associated with them. In contrast to that, psychedelics tend to not cause overdose deaths. They don't cause enduring neuropsychologic deficits. There are some exceptions. Ibogaine causes QT prolongation and cardiac arrhythmias. It has been associated with death. And these very potent synthetic psychedelics like bromo dragonfly and N-bomb have been associated with death. The main risk with these medications has to do with the psychological side of things. And this is the big difference between how we use them therapeutically and how they're used recreationally. The typical person that uses this class of drugs are high school students or people in their early 20s, no appreciation of their effects, no preparation, taking it recreationally. And in this setting, you have really bad outcomes. I mean, that part of the problem of what's happening with the zeitgeist now with psychedelics is everyone thinks they're a cure-all. You would think this from the lay media, and people are rushing to go out and use them because they think they'll be cured magically just from taking it. And that's a real danger. They can create psychotic-like states, so definitely they should never be given to people with schizophrenia or underlying psychosis. We make sure to rule this out. Hallucinogen persisting perceptual disorder is a very rare disorder, but it can be very disabling in its chronic form, where you have ongoing deficits in the visual field. It really has not been seen in research settings. It's typically seen in a teenager who uses it a lot in a recreational setting. I treated a couple cases in my private practice, and it's a very disturbing condition with really no good treatments. And this concept of hallucinogen addiction, I'm going to review some data showing that this class of drugs is not addictive, but they can be abused. You know, if you're getting in a car and you do LSD, that could be very dangerous. So you have some people that kind of overdo it and are chasing some big experience. And so it can be misused for sure. And if we look at the modern data with psilocybin, and this is data derived from clinical trials, ranging from open label to randomized controlled trials, populations ranging from normal volunteers to cancer patients or those with addiction. There have been 275 participants. This has actually been updated now. It's closer to 400 at this point. And the 529 doses is now closer to 800 doses, from very low to very high. And what's quite remarkable is that there have been no treatment-related SAEs. The one exception to this, there was a recent study of psilocybin in major depressive disorder and treatment-resistant depression. And the sponsor there did find at the higher dose that there were some increased rates of suicidal ideation. So whether that's a real thing or not, we'll have to do more studies. But before that, psilocybin had not been associated with any medical toxicity. It still has not been associated with prolonged psychosis or HPPD, and no evidence of addiction. Despite this, it's a Schedule I drug defined as high of the highest addictive liability and no therapeutic utility. But what makes a drug addictive? In animal models, animals will self-administer them repeatedly. You can get conditioned place preference, as Pavlovian conditioning that you get with all drugs of abuse. The nucleus accumbens, the mesolimbic reward system, robustly lights up in neuroimaging studies. with all drugs of abuse. And epidemiologically in humans, you will see data supporting use disorders. The psychedelics don't do any of these things. You can't get animals to self-administer them reliably. You have enormous tachyphylaxis that occurs to their use, so much so that after 3 days of taking LSD daily, there are no psychoactive effects. The effects are not reliably rewarding. They can be difficult and terrifying. They don't cause withdrawal syndromes. They don't appreciably activate the dopaminergic system. And epidemiologically, we just don't find people using these drugs daily and continuing to use them despite negative consequences. They just don't act like the other drugs of addiction. They are different, even though they're classified as Schedule 1. But the classification system, I mean, the most addictive drug, tobacco, and the most damaging drug in society, alcohol, they're absented from the system. So that gives you a sense that it's not a rational system. And here's an example of that. If you look at how addictive something is and the lethal dose of the drugs, the worst drugs in society are the opioids, alcohol, cocaine, nicotine, and the least problematic ones are LSD or psilocybin. Look differently, this is looking at harm to the individual and society. And the most damaging drugs in our society are alcohol, opioids, and crack cocaine. And the least problematic ones are the serotonergic psychedelics. So if we were to design rational drug policy, it would look much different than what we currently have. All right, let's talk about cancer. And this is the area that you guys know so much about. There are 14 million new cases worldwide of cancer. It's the second leading cause of global disability. And in the US, about 40% will develop cancer in their lifetimes. So it's a highly prevalent problem. Psychiatric distress and cancer is also very prevalent. And this is some combination of depression spectrum phenomena, anxiety spectrum phenomena, adjustment disorder with anxiety or depression. And the prevalence rates are as high as 30 to 40%. So a significant percentage of our patients will develop clinically relevant distress. And this distress is associated with poor outcomes, ranging from poor quality of life to increased hastened desire for death, increased rates of suicide. A cancer diagnosis in some studies increases the relative risk of completed suicide by up to 4 times. You have worse medical outcomes, and you actually have decreased survival from cancer. In particular, depression is associated with decreased survival, and whether that has to do causally with impairments in immune function is an open and interesting question. The evidence-based treatments to treat anxiety and depression and advanced cancer, there are medications commonly used and psychotherapeutic interventions, but their effectiveness is limited and mixed. For example, if you look at antidepressants and their efficacy in cancer depression, you look at meta-analyses, they fail to show that the antidepressants work any better than placebo. And you contrast this with other serious medical problems like stroke, where the antidepressants do better than placebo. For some reason in cancer, our antidepressants tend to not be better than placebo. Okay, so let's look at existential distress. And for those in palliative care, you know all about this. This is an unusual domain within medicine. It has to do with the human confrontation with death and what that provokes in people. And there's a kind of spectrum of responsivity to being told you have cancer or your cancer is getting worse, or you're facing your mortality. Some people cope with denial. I'm going to be okay. This is not a problem. Some say, wow, this is like a gift for me. This allows me to see what's really important in life and no longer focus on things that are not important. And then there's those that develop existential distress. And it's pretty common. Up to 25% of patients with advanced cancer will develop some form of existential distress. Some studies, it's even higher, up to 50% meeting criteria for the demoralization syndrome. And this has to do with a sense of loss of meaning or purpose, that life no longer has any meaning or purpose. People have a sense of loss of dignity, that things are futile, and they get disconnected from sources of love, attachment, meaning, and hope. It can be within themselves, and it can be in the forms of connection to work, family members, their spirituality. And when this happens, it's also associated with adverse outcomes like increased anxiety, worsening depression. It too is associated with the increased hastened desire for death. In particular, the demoralization syndrome is associated with hastened desire for death. And demoralization syndrome is a different construct than major depression. Sometimes they overlap, but actually the demoralization syndrome is a greater driver of hastened desire for death in patients with advanced cancer. Again, this is a vulnerable group that's at very high risk of the worst outcome within mental health field, completed suicide, but also worsened pain, diminished quality of life. So both psychiatric distress and existential distress, very prevalent, big unmet need, treatments that tend to not work that great. In the case of existential distress, there are some evidence-based, existentially oriented psychotherapies, but there are no known pharmacotherapies until we started testing psilocybin. And I had mentioned suicide. There's a greater relative risk of completed suicide, and it's really mediated by untreated pain, depression, and existential distress and low spiritual well-being. And I'm going to present some data. We did a secondary analysis that we published recently on psilocybin and its hastened desire for death and suicidal ideation. So there's this converging evidence that psilocybin, despite this recent trial and finding with treatment-resistant depression, which I would doubt is a real finding. I think people with treatment-resistant depression tend to have suicidality. It may have just been that it clustered in this one study, but we'll have to take a close look at it. But besides that, there's converging data that psilocybin has anti-suicidal properties. The National Survey of Drug Use and Health, a cross-sectional large epidemiologic study, has found lifetime psychedelic use associated with decreased suicidal ideation, decreased suicidal planning, decreased suicide attempts. This is in contrast to every other drug of abuse, alcohol, tobacco, cocaine, opiates, that are all associated with increased suicidality. And some clinical trials evidence from open label trial with psilocybin and one with ayahuasca with some evidence for decreased suicidal ideation. So this is a big question. It was, this was never taught to me in medical school or anywhere in my training. You have a dying patient. How do we step back and help them think about their death? In medicine, we are kind of programmed to keep people alive. The field of palliative care is different, but when I was going through my training, no one ever sort of posed this sort of thing. And I think most people don't want to die in a hospital setting. They'd like to die at home or home hospice, surrounded by family members. But unfortunately, this is still where too many people die in American medicine, in ICU settings. And I mean, tragically, we've seen with COVID, this is happening all the time. In the beginning of COVID, it was heartbreaking, and hearing stories of people rapidly getting sick, being admitted inpatient, disconnected from their families, alone in isolation, and dying. So this is unfortunately the norm in much of medicine. So this was also something, again, I only learned through this study, although I did learn this, interestingly, when I was a teenager. When I was 14 and 15, my mom was a hospice worker in Los Angeles, and she took me to this hospice in the San Fernando Valley. And I saw for a couple of years as a volunteer this construct of good death. I saw dying people with cancer and other disorders who were happy and living a meaningful life. They had their family members there. And it was really interesting. But when I did my oncology rotations, I saw none of that. I saw us treating people up until the end and people just suffering. So the construct of a good death has to do with stepping back and using the confrontation with the limited amount of time one may have to review their life in great detail. This is actually something we do a lot in the study. In terms of the preparatory psychotherapy, we do an extensive life review. And this can be helpful for anyone, to sort of step back and really review your life in great detail and go through the significant events and difficulties and accomplishments and relationships. Pain management is key. Spirituality and meaning become very key for people as they're confronting death. It becomes important for people to resolve conflicts that are outstanding, to have a sense of completion, spending time with loved ones, being able to make clear decisions about what you want, making time for final goodbyes and dialogues, and this, unusual thing of preparing for your death, which in some cultures they do a better job, and in some religious traditions, much of the time is spent, contemplating and preparing for death. Buddhism, as an example. So this was an article I published in 2018. It was a review of the use of psychedelic therapy to treat cancer-related psychiatric and existential distress. So in the historical era, this was from the 60s to early 70s, there were two main research programs. One was led by Eric Cass at University of Chicago, and the other was led by Stan Groff at Spring Grove in conjunction with Johns Hopkins. Eric Cass was this really amazing guy. I would think if there's one hero in all this, it's this guy. He's a Viennese psychiatrist in the mold of Viktor Frankl and Sigmund Freud. His family suffers religious persecution. He's Jewish. They ended up fleeing. He goes to University of Chicago and ends up being trained in both psychiatry and internal medicine, and becomes a pain researcher, treating people at the very end of life, inpatient settings, Chicago, with refractory pain syndromes. In the 60s, he hears about this new drug, LSD, and starts a research program studying the chemotherapeutic effects, meaning that this is going to be a drug to treat pain. Doesn't know anything about the unusual psychological effects. Ends up publishing two main studies. And his first one was really interesting. It was a comparative efficacy trial, single dose LSD, no preparation, no nothing. Just Dr. Cass comes in the morning, patient sticks out their tongue, he gives them 100 micrograms of LSD and comes back at the end of the day. Kind of crazy to think that somebody would do that, but that's how it was. And this was compared to two single doses of opioid, hydromorphone and meperidine. The setting was an inpatient setting at University of Chicago. These were end-of-life patients. Most had cancer, but some had ischemic and neuropathic conditions. And what he found was that acutely in the first 2 hours, the LSD group and the opioid group had similar antinociceptive efficacy. You'd expect this with the opioids. But what he found after that is, as the opiates anti-pain effects wore off, the LSD group did not. And what he found was up to 19 hours post single dose that there were sustained anti-pain effects with the LSD group. But interestingly, in addition to the pain effects, even more interesting, patients reported, I had this unusual philosophical experience. I experienced infinity, and I'm no longer scared to die. This was the very first report ever within medicine that a psychedelic could reduce fear of death. Cass followed this up, all open label, again, also single dose LSD in 128 more individuals. This time he had a psychiatrist in the room, and if somebody had a bad experience, they would give them Thorazine, but still not the Model 2 therapists and a patient and the careful monitoring or the integration. But what he found, again, was rapid analgesic effects that were sustained for up to 3 weeks. Also decreased psychiatric distress, decreased death anxiety. And again, patients reported these mystical experiences that they attributed to why they felt better. And this is a kind of crude drawing of the pain effects here. You can see there's rapid reductions of pain in the first several hours that endure for about 12 hours, and it sort of comes back up after a couple of days and then comes back down. So this is an interesting graph. And in fact, a new study that we have in our center that I'm going to be leading is picking up on this work and doing a double-blind placebo-controlled trial of LSD therapy in patients that have advanced cancer pain syndromes who are also on opioids. And so we're going to continue this line of research. The other program was more of the model that we're used to today. This was kind of the dream team of psychedelic research led by Stan Groff and Walter Pankey. And this was a group that it was an outpatient model. These were terminally ill cancer patients. Here they developed the two therapists, the preparation 6 to 12 hours, the dosing 8-hour sessions and integration afterwards. This was federally funded. They recruited 83 individuals, 53 of which got high dose LSD. And an analysis of 44, the systematic ratings of 31 of the individuals, what they found pre-post in this model was very similar to what Cass found: decreased pain, decreased depression, decreased anxiety, decreased fear of death, and a trend towards reduction of opiate use. So these two programs of research set the stage for what didn't come next, which was randomized controlled trials. Soon after the Controlled Substance Act hit, the music all stopped. But it was this body of research that in the modern era, Charlie Grobe at UCLA, Roland Griffiths at Johns Hopkins, and myself and our team at NYU looked at to design our current trials. So all of this has occurred since the early 2000s. There was one small pilot trial, randomized controlled trial of single dose LSD assisted psychotherapy in Switzerland. But I'm going to focus on the 3 psilocybin studies in the US. So this was a kind of intentional collaboration between our 3 groups. The UCLA study published first in 2011 in the Archives of General Psychiatry. Their dose was lower than ours. It was 0.2 milligrams per kilogram rather than 0.3. In retrospect, the dose was too low and it was underpowered. There were only 12 participants. But what they found, and this is a measure of anxiety, these are not statistically significant between group differences, but you can look, it appears that there's separation, that the psilocybin first group, this was a crossover at 2 weeks, appeared to have lower rates of anxiety, but again, underpowered. So the between group differences were not significant. But when they collapsed across groups pre-post, they did see significant pre-post differences, reductions in anxiety at 1 month and 3 months. Similarly with depression, not significant between group differences, but trends for the psilocybin group over placebo, and then collapse pre-post. They did find significant reductions at 6 months in terms of depression. And that set the stage for these 2 studies, one from Johns Hopkins, one from NYU, published in 2016. Hopkins, it was a trial, randomized 51 participants, advanced cancer, using single dose psilocybin assisted psychotherapy. Their control group was low dose psilocybin. And what they found, their first time point after was 5 weeks afterwards, and they had this big separation between the psilocybin first group, the high dose one, and the low dose active control. The effect sizes here were between 1 and 2 for these various measures. So large between group differences in depression and anxiety. The groups here were about the same at the final 6 months because it was a crossover, and the other group, the placebo, had gotten the high dose psilocybin. Reductions in anxiety at 6 months, single dosing, improved quality of life in the psilocybin group compared to placebo, and improvements in death acceptance in the psilocybin group. Looking at these in terms of how clinically meaningful, they were very clinically meaningful. So this is looking at response. This is defined as a greater than 50% reduction in depression. And you can see 5 weeks afterwards, there's a big separation between the experimental group and the control group. And looking at remission as well, at 5 weeks, about 60% are in remission from their depression compared to only 20% in the control group. Similar findings for anxiety. So let's get into our data here. Our publication, we recruited 29 individuals. This was a single dose psilocybin versus placebo. The control here was niacin. It was a crossover at 7 weeks. There was the preparatory psychotherapy, the all-day dosing. And after the crossover, there was another 26 weeks of follow-up until the end. The primary outcomes, co-primary outcomes were depression and anxiety. Secondary outcomes included measures of existential distress, quality of life, spirituality, and we measured the mystical experience with the MEQ. I work at Bellevue. I've been here 21 years. This is a hospital dedicated to the poor and indigent, but Bellevue wouldn't let me do this study here. They didn't want a negative media story. So we ended up predominantly recruiting from our NYU Clinical Cancer Center. So it was a skewed population. It was mostly Caucasian. The typical patient was a woman in her mid-50s that had a advanced reproductive type cancers. The majority had stage 3 or 4. And this was mostly adjustment disorder. These were people that did not have a history of psychiatric illness who met criteria for adjustment disorder with anxiety or depression. And we were able to get equal numbers in the two groups. In terms of AEs and SAEs, we did find some changes in blood pressure and headache. These were expected AEs with psilocybin that are transient. Psilocybin does not have cardiac toxicity. We did see people having transient anxiety. In fact, a lot of people had these very difficult encounters with their cancer or with death, and helping them through these difficult experiences, I think, was actually therapeutic. And some people did have transient psychotic-like symptoms that did not endure, but there were no SAEs, either medical or psychiatric. We showed that we could safely treat this patient population. And our main findings was that one day after getting psilocybin, the psilocybin group versus the control, there was this sort of rapid reduction in both anxiety and depression. There was a big separation between the experimental and control group. The effect sizes here range from 1 to 2 approximately. This is when the crossover occurred, and you can see the control group start to have these reductions in distress that start to approach the psilocybin first group at 26 weeks. In this one here, they become isomorphic. This is a measure of depression. But the biggest finding really was this head-to-head race, that we found that psilocybin was a rapidly acting anxiolytic and antidepressant, single dose that lasted at least 7 weeks, but the data suggested it may have been as long as 6.5 months. And in terms of the clinically meaningful effects, we also, like Hopkins, these were highly clinically meaningful. So one day after getting psilocybin, this group here, about 85% were in remission from their depression compared to only 20% in the control group. And this endured at 7 weeks prior to the crossover. We also found that psilocybin produced reductions in demoralization syndrome and hopelessness, improved spiritual well-being, and improved quality of life compared to placebo. We found that psilocybin occasioned these mystical experiences compared to placebo. And we did a mediation analysis. We looked at the mystical experience 7 hours after getting psilocybin and found that it partially mediated reductions in anxiety and depression at 5 weeks. Johns Hopkins found something very similar. And so the mystical experience emerged as a potential psychological mechanism of action. We went on to collaborate with CUMC on this study with Stacy and Jim. This was a long-term follow-up. We followed patients out to close to 5 years. Caveats being, it was a crossover, it was a long time afterwards. So we cannot draw any causality, but we did find collapsed across groups, these long-term sustained reductions in anxiety and depression at 4.5 years compared to pre-treatment baseline. And we found continued reductions in demoralization And also death anxiety was significant here. Interestingly, almost none of the participants reported in the intervening years that they had gotten any treatment for cancer distress. Nobody had gotten psychotherapy, and hardly anybody had gotten any pharmacotherapy, which made us think that maybe it was a result of the psilocybin experience. And the participants attributed the psilocybin experience to this. And in fact, when we asked them how meaningful and spiritually significant the experience was, at the long-term follow-up, 71% said this was the top 5 most meaningful experience of their entire lives. And close to 100% said it was the top 5 most spiritual experience of their lives. So these are very meaningful, spiritually oriented experiences that our participants had. We recently published a secondary analysis looking at suicidality. And what we found, I mean, there were only 11 people. This was not powered to take a look at this. It wasn't designed to take a look at this. In fact, we ruled out anyone that had significant suicidality. But there were, looking at this measure of passive suicidal ideation, these were not significant between group differences, but within group differences, this is the psilocybin first group, there were significant reductions in suicidality at 8 hours, 2 weeks, and 7 weeks. And we didn't see within group differences for the placebo group. We looked at this loss of meaning factor in the demoralization scale, which has been associated with suicidality and did find significant between group differences. When we sort of increased the power by collapsing across groups, we did find significant pre-post reductions in suicidal ideation and loss of meaning that endured for several years. And we looked at the link between this loss of meaning subscale of demoralization and suicidal ideation, and did find a correlation between these two constructs, sort of suggesting that a loss of meaning in patients with advanced cancer may be the thing that is driving or mediating suicidality. So if we need to design a trial differently to really see if this is a true effect, but it may be that loss of meaning drives suicidal ideation and that psilocybin can repair that in some way. So to summarize, we showed that we could safely and feasibly recruit from the sample that psilocybin-assisted psychotherapy was a rapidly acting anxiolytic and antidepressant with highly significant clinical outcomes. And the effects were sustained in terms of depression and anxiety for several weeks and possibly several years from single dose. There were potentially rapid and sustained anti-suicidal effects. We found reductions in existential distress, including demoralization and death anxiety. We found improvements in quality of life. We found these to be among the most spiritual and meaningful experiences of people's lives. The mystical experience emerged as a psychological mechanism of action. So this study was published. It ended up on the front page of the New York Times on December 1st, 2016. This is a participant in the trial who I treated, a 21-year-old at the time NYU student who had Hodgkin's lymphoma, who was told that he was cured, but didn't believe it and had this horrible fear of recurrence and demoralization. And he had a profoundly healing experience that he attributes to that session that went on to alter his life. Now, 8 years later, he went on to medical school and is thriving and doing well in life. So there were a couple of former presidents of the American Psychiatric Association and about 10 other people that wrote articles commenting on the study, and all of them to some degree or another urged the research to move forward. But with the caveats that, let's not get ahead of the data, let's not be overly exuberant here, let's sort of see if this is a real effect or not. So this really has emboldened me and others to take this program of research forward and to replicate these findings. And the idea here would be to do phase 2 and 3 trials and to focus on end of life, but also every stage of cancer, early diagnosis, chronic cancer, survivorship, that these are all areas where you have very high rates of anxiety and depression and existential distress. It's not just in end of life. In fact, early diagnoses may be the place that is most salient to intervene. And therapeutic targets range from psychiatric distress to existential distress, quality of life pain. The funding has mostly come from private philanthropy, but the next phase of things, the idea is to have a combined funding mechanism from NCI and biotech. And this is something actually that Stacy Fisher and Jim Grigsby and I are getting close to, hopefully, at NCI. We keep trying, and we recently got a pretty good priority score, putting us at the edge of finding for a phase 2B study and 200 participants. And hopefully, fingers crossed, we'll get some good news on that soon. The idea is to have a better design, larger sample that's more powered to look at psychological mechanisms of action and interrogate other mechanisms of action. Parallel design rather than crossover. Be good to have a better comparator that has better blinding integrity, and good to, and if we can show efficacy, important to design trials so that we can understand how they work. Is it the psychological side of things? Is it the mystical experience? Is it having something to do with enhanced learning? We know that psilocybin increases the trait domain of openness. We know it increases cognitive flexibility. Are these psychological change mechanisms? But also to do neuroimaging and look at neuroplasticity markers and inflammation to see if on the neurobiologic side of things, what may be driving improved outcomes. So the next step is really going to be working across institutions like Colorado and NYU with joint funding with NIH and biotech. And if we can, this program of research can show efficacy, it could lead to the potential historic rescheduling of psilocybin. It'll be constrained by the REMS process. You know, hopefully they will not allow you to go to CVS and take it at home to do it. You really need skilled therapists to administer this for safety and efficacy. It needs to be overseen carefully. The issues of reimbursement and equity and distribution and fairness will be important. And I'm always aware that I'm like a dilettante here. I'm an addiction psychiatrist. I'm not a palliative care doctor or a psycho-oncologist. But if this works, I think the places that make the most sense would be hospice centers, palliative care centers, cancer centers, and any stage of illness could be targeted. So wanted to thank you for your time. And if we have any time, I'll take questions. Thank you.
Steve, thank you so much. I am happy to take questions in the chat, or if people want to raise their hand. We've got a pretty wonderful turnout today, so I may not see your hand. So feel free to just start speaking if you have any questions. I'll go ahead and kick us off. Steve, I think from our conversations, one of the first steps, it sounds like, from the biotech industry is some interest in recalibrating the dose and doing some dose response testing. And I'm wondering if you can share with us a little bit about that rationale.
Any biotech or pharma development program with the drug, typically before phase 3 involves a dose response study. And that had not been done in this area. I mean, it kind of had been. Hopkins used 1 milligram as their active comparator. UCLA used about 14 for their dose, and our group in Hopkins at the high end used 21 and 22. But that's not exactly a dose response study. So it'd be good to know what's the minimally effective dose. You really need that, and the FDA and sometimes requires you to do that. So this biotech company, Reset Pharma, is planning a dose response study as a phase 2B supportive study before the phase 3 trials.
A quick question. Can you hear me? Oh, great. Were there any medical related rule out criteria where, when you say there were no findings of serious adverse effects in terms of like renal, hepatic, cardiac in the psilocybin studies?
So we ruled out people that were unstable medically, if they had heart failure, end-stage renal disease, or hepatic illness. We did not include those individuals. And in that context, we did not have any adverse medical events, any serious ones. I mean, the most we had are things like nausea, and headache, and some transient increases in blood pressure.
Thank you.
I have a question. So my name is Lauren Baumgartner, and I'm a music therapy intern at UC Health. I wrote my master's thesis on music therapy as an adjunct to psychedelic therapy in a session for an individual with treatment-resistant depression using psilocybin. And I looked at how the musicality of these sessions could impact positive therapeutic outcomes, such as supporting these peak experiences and autobiographical insightfulness. So my question for you is, with your expertise and all your work, do you think that it could be potentially beneficial for music therapists and other creative arts therapists to become involved in this research and in developing protocol?
Very much so. In fact, if you look behind me here, you see a bunch of pictures. People think they're kids' drawings, but these were from psychotic patients at Bellevue. My first 6 years here, I ran an inpatient unit for patients with schizophrenia and addiction. And we had a very robust music and art therapy program, and the patients wouldn't speak to the doctors, but they would communicate through art. So I'm a big believer in that modality. And music has, in indigenous cultures, music is almost always part of these experiences. And when these models were developed in the 60s and when we picked up on them, it was like almost a default. Yeah, of course, you would need some musical background. So I think it's really important, but I'm not exactly sure how it is. And I think we need to do studies to vary some of these things, that maybe we'd do a study with no eye shades, or one with no music, or maybe the music would vary. I think the music is really important, and we developed a playlist. Everyone has the same playlist that we painstakingly developed over many months that we thought would go along with the pharmacologic effects of psilocybin. And we have a playlist, we can share it. I know Hopkins and others have their own playlist, but this is a really interesting area that needs to be explored more.
Thank you. Yeah, I interviewed Dr. Mendel Kalin for my thesis. If you've heard of him,
Of course.
He's awesome. But yeah, my whole argument is like having live music in the session. So that's what I'm really curious about. And thank you for that response. So.
Sure.
We have a question in the chat from Jamie Beachy, who is at Naropa University. Asks, have you all considered collaborating with professional chaplains, considering the spiritual themes and questions of existential meaning that contribute to positive outcomes?
Yes, in fact, at Bellevue, we have a chaplaincy program. I'd worked with them in the psychiatry department for years. And one of our coordinators, who went on to become a project manager and now therapist in our studies, is in a chaplaincy internship. And so for the very first time, we are working with a chaplaincy program to have an intern to combine those modalities. So, and we're also, another study that we're about to publish is a collaboration between NYU and Johns Hopkins, where we administered high-dose psilocybin to religious professionals like rabbis and priests and an imam. And that's a follow-up to the Good Friday experiment. So we're trying to see how psychedelics may help inform religion and specifically religious trainees. So more to come in that area.
Any other questions? Well, please join me in thanking Dr. Steve Ross for a wonderful, wonderful overview, history, current evidence. That was phenomenal. Thank you so much.
Thank you so much for having me. Wishing everyone a great rest of the day. Bye.